Welcome to the lecture on Quality Improvement, Patient Safety, and Health Information Technology. In this presentation, we will be defining healthcare quality and explaining different aspects of healthcare quality and quality improvement techniques. According to an Institute of Medicine report, quality of care is the degree to which health services for individuals and populations increase the likelihood of desired outcomes and are consistent with current professional knowledge. So who defines healthcare quality? The answer is a lot of people do, and each does so from his or her own unique perspective. Take healthcare providers, for instance. They are more likely to view quality as the application of evidence-based professional knowledge to the needs of individual patients. Patients and families, on the other hand, may place more importance on how the provider talks with them or how long they have to sit in the waiting room. Payers value patient satisfaction and use of preventative services rather than focusing on clinical outcomes of the patient. And regulatory bodies like the Joint Commission or the Centers for Medicare and Medicaid Services are professional organizations, such as the American Medical Association, view quality as conforming to their standards. The image presented here is a composite of 4 intersecting circles, each containing a category of entities that help define quality of healthcare. Healthcare providers, patients and families, professional and regulatory bodies, and payers. They all define quality slightly different from their own unique perspectives. On this slide are some of the regulatory bodies and organizations that help define and bring consensus around quality improvement issues. A nonprofit organization, the National Quality Forum, is charged with improving the quality of healthcare in America. They have a 3-part mission that includes working in partnership to achieve consensus around performance improvement based on national goals and priorities, supporting standards for publicly measuring and reporting performance based on national consensus, and third, supporting the use of outreach programs and educational interventions to attain national goals. The National Committee for Quality Assurance is a private 501c3 not-for-profit organization dedicated to improving healthcare quality. It develops quality standards and performance measures for a broad range of healthcare entities. These measures and standards are the tools that organizations and individuals can use to identify opportunities for improvement. The American Medical Association's Physician Consortium for Performance Improvement, the PCPI, is a national physician-led initiative dedicated to improving patient health and safety. According to their website, they achieve this by identifying and developing evidence-based clinical performance measures and measurement resources that enhance quality of patient care and foster accountability. They also promote the implementation of effective and relevant clinical performance improvement activities, and they're responsible for advancing the science of clinical performance measurement and improvement. The Joint Commission is an independent not-for-profit organization that accredits and certifies more than 19,000 healthcare organizations and programs in the United States. And finally, the Institute for Healthcare Improvement, the IHI, is an independent not-for-profit organization located in Cambridge, Massachusetts. The IHI is concerned with investigating new models of care and how they perform while partnering with patients, families, and healthcare professionals. In addition, the IHI is focused upon encouraging and supporting change while helping to maintain the momentum and commitment to serious and transformational health system change. Finally, the IHI is committed to innovation and wide-scale adoption of best practices, high-quality care, and cost-efficient services for all. Each year, the Agency for Healthcare Research and Quality, or the AHRQ, partners with the Department of Health and Human Services to report on progress and opportunities for improving healthcare quality. In 2009, the report concluded that the U.S. healthcare system needs to be improved, especially for the uninsured, and that patient safety and healthcare-associated infections warrant urgent attention. Although quality is improving, the pace is slow, especially in preventive care and management of chronic diseases. Some Americans receive health care that is worse than other Americans. These disparities are often due to differences in access to health care, provider biases, poor provider-patient communication, and poor health literacy. The AHRQ tracks gaps where some people receive poor or worse health care than others and looks for improvement over time. Emphasis is on race, ethnicity, and socioeconomic status, but also includes attention to broadly defined priority populations, groups with unique healthcare needs or issues that require special focus, such as recent immigrants or people with limited English proficiency, women, children, older adults, residents of rural areas, and disabled individuals. So how are we doing in terms of healthcare quality? Many of the measures available to us would suggest we are not doing so well. In a national phone survey, McGlynn and colleagues found that participants in the survey received 54.9% of recommended care. There was hardly any difference among the proportion of recommended preventive care, only 54.9%, recommended acute care provided, 53.5%, and recommended care provided for chronic conditions, 56.1%. The study raised concern for the health of the American public. The seventh report of the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure stated that 2/3 of hypertensive individuals were being inadequately treated. Seda and his colleagues, in a review of data from the Third National Health and Nutrition Examination Survey, or NHANES, which is a cross-sectional survey of a nationally representative sample of the non-institutionalized civilian U.S. population, described that 2/3 of individuals with diabetes had uncontrolled levels of hemoglobin A1C, a measure of diabetes control. In another study, Afonso and colleagues also described that 2/3 of individuals with elevated cholesterol levels had not reached adequate control. This is not only true in the world of ambulatory care, the same kind of quality concerns that are found in the hospital environment. Examples of this include the level of hospital-acquired infections. In a recent review, Umshed and colleagues found that anywhere from 50 to 70% of these infections are preventable. Another measure of quality lapses in the hospital world includes the high rate of readmissions. 1/4 of the patients admitted with heart failure in this country will be readmitted within 30 days. The lack of quality is not only reflected in the outcomes of care, but also in the patient's experience of care. In a national survey conducted by the Commonwealth Fund's Dr. Beal and colleagues, they found that only 27% of adults who actually had a primary care provider could easily contact their physician over the phone to obtain care or medical advice or get timely office visits. In another national survey, found that only half of the adults receive very good information, find it easy to get an appointment, or do not feel they waste their time when they visit their physician. These are just a few examples of the state of health care in the United States. Given the current quality of care received by Americans, the introduction of quality improvement initiatives is imperative. As we look at the different ways to improve our healthcare system, we should consider the role of health information technology and how it can play a role in this improvement. Paul Batalden, Medical Director of Healthcare Improvement Leadership Development, famously stated, "Every system is perfectly designed to achieve the results it achieves. Thus, the way to improve our healthcare system is to redesign it." There are a number of methodologies used to improve the quality of a system. Model for improvement, lean thinking, Six Sigma, theory of constraints, customer-inspired quality, and many others. The detailed review of these multiple methodologies is beyond the scope of this lecture. However, at the core of these methodologies, there are the same basic principles that we will now review. The aim we set needs to be very specific. If at all possible, a numeric aim should be set. It is very difficult to improve a system if your aim is vague. We will improve our infection rate is a much harder aim to attain than we will cut our rate of hospital-acquired pneumonia by half. However, this aim, although better than the former, could be improved. What is your current rate of infection? Where are the majority of infections happening? Is there any shift or time of year where these infections are worse? The inclusion of all these aspects into your aim denotes an understanding of the system you are working on and assists you in achieving your goal. A better aim may read, "We will reduce the number of hospital-acquired pneumonias from the current 35% to 15% in the ICU. Assigning a timeline is an important component of setting an aim. If you don't have a timeline to achieve your improvement, it is difficult to see it through or to engage a team that usually is busy with many other responsibilities. Making your aim measurable will assist you in seeing it through. There are very commendable aims that cannot be accomplished because they cannot be measured. An example of an immeasurable goal is, we will make 90% of our patients happy in 6 months. Although it is specific and it has a numeric value, we have to choose a variable that can be measured. How will we measure if they are happy? A better option for this aim could be 90% of our patients will rate our services as excellent and will state they would recommend our services to a friend or family member. This captures the essence of the original aim and allows you to measure it. Make sure you challenge your team with the aim you choose. An aim you can achieve in a week may make you look good in the short term, but is unlikely to bring permanent improvement to your system. As we mentioned before, measurement is an essential component of quality, since you must have the ability to measure change in order to direct change in the appropriate direction. There are 3 types of measures we will be focusing on. Process measures. These measures look at the steps in the system and determine if the system is performing as it should. Performance measures will improve before the outcome measures do. They assist us in determining if we are on track to get the improvements we want to see in our system. Outcome measures. These measures determine the impact of our changes in the system. They measure the results from the view of patients about their health and well-being. These measures may also look at the impact of other stakeholders such as payers, employees, or the community. Balancing measures. These measures are designed to look at the whole system and make sure we are not causing new problems in other parts of the system while trying to fix something else. Although these measures tend to be measures of cost or patient experiences, any of the process or outcome measures could be used as balancing measures if they help us look at the whole system. We will now present 2 examples of measures selected for improvement projects. The first is a hospital example. In this example, the staff of the ICU set an aim to reduce the number of ventilator-associated pneumonias. They set a specific aim with a clear timeline. For process measures, they choose factors that have been chosen to relate to VAP, ventilator-associated pneumonias. For example, the more days a patient is connected to a ventilator, the more likely he will become infected. The outcome measure is actually the number or rate of VAP. This measure ties directly to the aim. In this case, staff members have chosen to use cost of care as a balancing measure, since there is a chance that by incorporating the changes they must decrease the rate of VAP and the cost of care will improve. They also included the rate of reintubation as a balancing measure, since it is possible that some of the changes they incorporate may cause patients to be extubated too soon. These are 2 examples of how balancing measures look at the rest of the system. In our ambulatory example, the team members want to improve their access to care. To do so, they will reduce the time it takes patients to get an appointment. In this case, the process measures are the supply, or the amount of slots available for practitioners to see their patients, the demand for appointments, and the no-show rate. The staff chose to include the no-show rate in the process measures because they believe that by reducing their no-show rate, they will have more space to see patients sooner. If they thought that the changes they wanted to incorporate would increase the number of no-shows in the schedule, they would have added this measure to the balancing measures. The outcome measure is the 3rd next available appointment. It is a good measure of access since it disregards appointments that are available due to last-moment cancellations. Again, the outcome measure ties directly to the aim. Finally, the balancing measure the staff chose is a measure of patient satisfaction. As you can see, setting a measurement strategy is not cut and dry. You need to make some assumptions regarding where you envision your system going. After you set your measurement strategy, it is time for you to consider the change you want to test. As you consider change, you will first need to decide on basic concepts or strategies that you want to focus on. Overall, ideas for change will lead you to improvement, but they are not specific enough for testing change. In our VAP example, our concepts and strategies should be reduce the number of ventilator days, reduce oversedation, and improve oral hygiene. Once you have established the overall categories, you will design tests to measure change. To accelerate improvement, the tests of change need to be small, fast, and frequent. This way you will be able to build new tests of change on your initial improvement and head towards your aim. Examples of tests of change in our example could be something of the following. To reduce the number of ventilator days, we could have the respiratory therapist test the settings every 2 hours to determine when a patient is ready for extubation. The round should include discussion of extubation for all patients. Trials of spontaneous breathing could be included as part of the routine. As you can see, these are specific tests that can be done fairly fast and of which we could have the results in a day or two. To determine the effect of a test, you may need to include measures and discussion of the test. Continuing with the example we have been using, we could meet with the respiratory therapist to determine at the end of the first day how the tests are going and determine if they need some tweaking. In designing your change package, you may want to consider using pre-existing change packages. These are built by quality improvement professionals based on scientific evidence. This is an example of one such change package. The table contains a partial copy of the California Academy of Family Physicians Diabetes Initiative Care Model Change Package. It was originally developed by Lumetra, California's quality improvement organization, under contract with the Centers for Medicare and Medicaid Services to assist practitioners to improve the care of patients with diabetes. The final component of improvement is learning about your health system. Intertwined in all aspects of improvement is the concept of the importance of understanding your system in order to be able to improve it. This is based on a system theory proposed by William Deming, a well-known statistician. His theory of profound knowledge is based on the principle that each organization, whether it be a department or a site, is composed of a system of interrelated processes and people. Improvement of the system depends on how the capability to organize the balance of each component to enhance the entire system. Thus, understanding and learning about your system is essential to improving it. This presentation covered the quality of care received in the U.S. and how it needs improvement. Quality improvement is an ongoing process that includes the setting of an aim and a progressive measurement, change, test, and understanding of the system. The references for this presentation are included here. Thank you so much for listening.